The main requirement was to contain really the cost of IT support in order to do QI or improvement in general. And that really means you have to pull data, have to be able to pull data from a number of different sources, no matter where they are. Claims, for example, externally provided services have to be able to be integrated with the rest of the data sets in order to provide a complete picture. And as I mentioned before, things like patient satisfaction and complaints, but things that might not be as obvious, like MDFTE, how many hours is that clinician working in a practice, may be a useful variable to normalize some data with. General ledger data was useful for us to calculate costs and to help us manage costs at the, what we would call the medical home level. The three key elements that I'm going to highlight through the demonstration are the addressing of HIPAA concerns. This is a very HIPAA compliant design, and we'll go into that in a minute. And then we're going to talk about what we call cohorts. How are patients grouped together in this tool, and what flexibility, which is nearly infinite, you have in terms of grouping patients, not only around disease groups, but around any kind of functional variable that you need to group these patients about. And then the facts about the patient we call concepts, and you'll see those as columns in a registry setting. We draw the tool as a HIPAA control unit, and I'm going to use this drawing to show you some of the capabilities in a moment, but these are the ETL extractors from EHRs, from practice management, from lab, from general ledger, whatever, they get plugged in here, and normalizing box that normalizes that data so that it looks similar to other clinics' data and can be compared, and then three pipes through which we can pipe that out to a browser or to a data exchange system, either using identified data, de-identified data for external work, perhaps for a public health application or for a research application, and aggregate data when we need to report numerators and denominators outside. The units can be connected together in a setting. Just imagine the entire area of Buffalo, and separate entities with separate EHRs, separate practice management systems can then present a common view. This is a proposal we gave to the County of Fresno here to create a regional asthma registry that will be administered by the Fresno Madero Medical Society. A clinical study, so the kind of stuff that Dr. Jack Foggs does with DARTnet and with this network of researchers can be fed in this manner using a de-identified data feed. And the type of reporting that we do for a Kansas City Quality Improvement Consortium of numerators and denominators can be delivered in this manner. And largely these feeds are, obviously many can be active at any one point. Here's a showing of a hospital pushing discharge information out to a clinic. We're beginning to deploy the first of these commercial ones in Kansas City at this point. And I'll skip over this. I'm going to pull your eye to the fact that some of the data elements are harvested from your systems, but many of these data elements are what we call derived concepts, and we have a very extensible process to allow you to derive concepts. So I'm going to stop there for 1 minute and see if there's any pressing questions, but we're going to go through the demo and then we'll open it up. Any pressing items?
I think we're okay right now.
Very well. So, I would have logged out earlier, but this thing will time me out if I'm on for too long. So I'm logging on to the system here using a browser. This is secure access, and the software is running on a cloud. These are all virtual machine based. And I'm logged on as a provider, Elaine Davis, and I'm going to pull out her complete panel and show you what a cohort view looks like very quickly. This is Elaine Davis's patient. You can see that the provider here is Elaine Davis, and that's how the group is selected. This cohort, therefore, is anybody whose provider ID is Elaine Davis, and she has 1,846 patients in her panel. Each row is a patient, and each column is what we call a concept. We have a published dictionary of about 600 concepts that are pulled for every single patient, and of course some of them are applicable only to some of the patients, but you can see concepts such as basic age and gender, the provider, the last or the next primary care visit, but also things like the number of primary care visits in the last 12 months, so that with a simple click of the bottom, these are all sortable columns, you can bring to the top the frequent users of the system for Elaine's panel. All of the columns are sortable that way. Down to the right here, I'm showing you some columns that have to do with the membership of some of the other registries or disease groups that you might have. You can see here several columns on hypertension, hyperlipidemia, CHF, but also you see that we could have theoretically more than one column on diabetes, and actually in any disease. This column here, for example, uses the HEDIS process of finding a diabetes code in the claims data, whereas this column here looks at the underlying problem list and tells us whether they're set in that. We'll see in a minute that that's an important issue. And I'm going to demonstrate later, but you can keep track of a care manager that's associated with the patient. You can bring report links to documents to view reports. So these are concepts that are dropped into this view. Many different views can be made. In fact, I'm going to open now from the disease management site, the diabetes in the problem list cohort for Elaine Davis. So here we now show a second tab. You can see the complete panel tab is over here with 1,846, and the diabetes problem, Dr. Davis is here with 230 of her patients having the property of being diabetics according to the problem list. And you can see the first thing in this cohort view that the columns or the concepts that are listed here are obviously different than what you would see in a general population panel, because this might be more useful to work with for diabetics. There's additional something called the query builder tool that allows the user themselves to narrow this set to a smaller set or to reconfigure the order in which these are displayed, and you can really have multiple different views of any roster that you like. At the top of every cohort view, you have several sections here that I'm going to go through in detail. A filtering option section allows you to filter the cohort that you're in by any of the criteria. So if I pick in the diabetes problem list here in the general population for Dr. Davis, and I select that data, you see that we end up with the same 230 number here in this general population tool that she has over here. These filters can be combined, so I can, for example, say, what about people who have a diagnosis of diabetes in the problem list but have not been seen with an ICD-9 of 250 in the last 2 years? And we find indeed that there are 18 people in this panel who all have a yes in the column of problem list and a no in the HEDIS equivalent column. So this is a group of people that Elaine Davis's RN might manage and see why these patients have not been to a visit where they've coded a diagnosis of diabetes. An equally interested list can be viewed by turning those around, for example, and finding how many patients in her panel are coming in with a HEDIS criteria of diabetes but have not yet been entered into the problem list. So we teach this tool in about 2 hours in a structured training class to the workers at a medical home, so that they're able to independently take this kind of management in conjunction with their care team. In the other view, the diabetes view, you can see that the items in the filter are also configurable. You can drop any concept into the filtering option, and that will manifest as a particular kind of view. So for example, I can look for people who have a glycohemoglobin that is less than 7, but at the same time, and are diabetics, so I'm in the diabetic list, and have a LDL greater than 130, for example, any combination that you might want. So this finds 6 people here that meet that criteria. We can again sort. Here's a interesting column called the average of the last 3 blood pressures within the last 3 months. So in the case of Dr. Davis, they might want to then take these patients and make them belong or go to a care management process. So what I'm going to do at this point is bring up a separate browser so that I can log in as a different user, and now I'm going to log in as Alice, who we pretend to be a care coordinator or care manager. Alice could be part of this facility, or she could be working in coordination with that facility. And Alice's panel is driven by a different criteria, obviously. So Alice has 2 patients in her panel currently that have been referred to her, and that is 2 patients whose manager is Alice White. And in fact, you will see that Alice is listed here as already care manager for these two patients here. Our tool is completely open to other applications that we write for you or that you can write yourself. So if I take individual patients, like these 2 patients here, Joseph Barker and Joseph Jensen, and I dial the care manager application, and I say, let's assign these to Alice White, and I push that. Those records are then submitted to the care manager application, which is then gonna tag the care manager column over here with Alice's name. Let's see if that's done already. Get the data again. Okay, so the application has now tagged these 2 entities with Alice's ID. And if I return to my other browser here, where Alice is working, and I refresh that screen here, Alice now has inherited 2 more patients into her panel that have been assigned to her. So we started using this type of mechanism to manage workflow between a variety of nurses or other kinds of coordinators that were handling patients. So for example, a diabetes type of educator that might be managing a panel of 80-some patients that were assigned to her to take a first crack at taking one of these patients and doing some one-on-one work with them. When one of these patients meets their criteria, Alice herself can take this and use the care manager application here to graduate a patient, for example, and post that. She might run into a patient that is more difficult. I need to go to a higher level of service. So let's take this Willie Jones here, and let's pretend like I've worked with Willie for a while now, and they really need some work with depression, because this is not something that I'm going to be able to help as a dietitian. So I might take that and pass that to my my coworker, and in this case, I'm going to post them to Bob, who's in charge of the mental health coordination. So I'm going to assign that patient over to Bob. And again, the care manager column, currently Alice has those. Let me see if this is done at this point. So Alice is back down to 2 patients here in her application. And then if we view, let's see, I think I'll go here. If we view in Dr. Davis's thing, you can see that the Alice has her 2 patients back, 2 have graduated, and 1 has been passed over to Bob Jones for his work. Any questions with that functionality? I'm gonna now show you
Anyone have any questions?
measurement. So
We're good on
every
questions, Tomas.
disease area has the types of measures that you would want to have out there. This is a metric dashboard view for the diabetes problem list roster, which means that the denominator being used here for diabetics are people with diabetes in the problem list. If you wanted a HEDIS view of the diabetes metrics, you can also get that by going to the diabetes HEDIS view and using this. So oftentimes we might be working internally with a view, which is what I would do here at Palo Alto, work with a metric dashboard there, and externally you can see that that first number changes from 47 to 48, and in most cases a very small number, but clearly the denominators are different or tracked different in the tool. The tool is built so that you can dial up any provider here that you have permission to see. So I don't know if we have another, here's a Debbie McDonald's provider. If you have a department or a location that you'd like to compare her with, you dial that. And let me go back to Elaine Davis here for a moment and show you that Elaine can then, or her staff can take this column here, for example, patient diagnosed with diabetes with a A1C less than 8, and if I click on her score of 69%, it's going to open up a registry view for me with the list of patients that meet that criteria. Let me talk that back up again. Oops, that did not come through. Let me open up. I'm sorry that did not come through. I will check on that in a minute. Show you the A1C control. So for any metric, you can drill down and look at the use of A1C, and in this case, let's measure providers with less than 8. You can look and add a provider view to your curves, and you can look at the scores of Elaine Davis compared to the general population over here. So these are metric functionality, and I think one of the last things I want to show you before I pause is a use of the patient summary tool. So let me put here my scores again. I'm going to look again for patients less than say 7.5 and an LDL value greater than 130 to show a number of patients. If I pull any of these patients up with a patient summary, as far as looking at their drill down, it'll give me kind of a point of care alert that the LDL is out of whack, but it's showing me that the rest of the variables are taken care of and done, and that we don't have at all a microalbumin done in the last 12 months. It hasn't been done at all. We can pull patient summaries from any patient in that manner. Obviously, all of these folks are going to have an elevated value there, but if I remove this criteria, for example, and get the data again, and then pull one of these other folks, you're going to see a different pattern here with this patient having an A1C greater than 10 and therefore not meeting the less than 9 criteria, no foot exam, and the LDL is out of whack, but these other things are in control. So this is the patient summary kind of functionality. Want to show you that I was asked if I could link out to the medical record. Our tool can call out to the medical record, so I'm just demonstrating to you that if I click on here, I can take you to any mock application. This would tie into your Cerner or your Allscripts system and bring you straight into the record of that patient. So our tool can hook in, hook out of those folks. Lastly, what I wanted to show you was the use of documents integrated with your system. Let me see if I have any here. No. Panel. Remove these criteria. So I'm going to go back to my complete panel. I think we put some reports here. So if you have documents that need to be viewed, they can pull in as documents. So for example, a social worker report for this patient would open up as a PDF document. We've done, as I mentioned before, the integration of textual and PDF type documents with our tools, so that the use of external documents, a discharge summary, for example, can be shipped in for this particular patient, and we'll pull out this particular patient's hospital discharge. So again, that kind of functionality we're deploying now at a hospital in Kansas City. That's in partnership with one of the groups that we're handling. The very last thing, I keep saying there's one more thing, but if the functionality of the tool, if we're looking at patients that are, for example, greater than 130 here, and if I look at the entire medical home, and if I have permissions to do that, then that criteria gets executed for the entire patient set in that medical home, so that I've now found 75 people in the medical home who all need some work with their A1, with their LDL being greater than 130. And again, the medical assistant or the care team coordinator can select any number of them. This time, maybe it's going to post them to a messaging application that is going to send a message to those patients to come in for an appointment or whatever process we've defined for these patients. So let me stop there. And turn it over to you, Jeff, to guide the discussion. And if people could speak into the microphone, you could repeat the questions if they're from a person sitting far from the mic.
Yeah, I'm going to pass it around.
Okay.
Okay.
Does anyone want to start questions?
Hi, to us, it's
So
Peter
are there any-
Winkelstein. I'm the
Yeah, hi.
CIO for UBMD, and I just want to run
Yeah.
some of the basic technical back-end questions by you. First of all, let me
Sure.
make sure that I understand the architecture. So it sounds to me like you're running an ETL against our systems and pulling that data into a data warehouse and then running your tool, the SQI tool, against that data warehouse. So the questions, assuming that's correct, the questions I have for you are, where is that data warehouse hosted? I'm just going to give you all the questions because of the awkwardness of the microphone, and then maybe you can run through them. So where's the data warehouse hosted? What's your experience of the mapping effort required on our end to create the ETL, because each EHR is going to be different, presumably, or each data source is going to be different. And then how does that ETL run? Is that a nightly extraction? And if so, what's the impact on the production system? How long does it take in general to run? Those are my basic underlying questions as far as the architecture goes, but if there's anything else you care to add, that'd be great.
Sure. Very good. So I'm putting in a little schematic of the architecture. There are 3 modules that come with the tool: an extraction tool that we call the harvesting tool that harvests and normalizes the data extracted. It's what you would call your ETL. The enriching module, which creates these derivative concepts that you saw columns for example, the count of the number of visits in the last 12 months is a derived concept that looks at the visits that have been extracted from the system and adds a column to that in a very simple way. So that's the enriching module. And then the viewing module, which is what you were actually looking at, the registries and the measurements that are coming and being delivered through a browser to look at that. The top 2 modules run on Postgres database, which is an open source SQL compliant data set, and they're running on a virtual machine, on a cloud server. I can run that on your private cloud, or I have a public cloud. We have a fully encrypted virtual machine that is running completely safe and HIPAA compliant, but we can put this on your cloud. You have complete access to the tables that are produced by the enriching module. The extraction module we do for you. It takes us typically less than 6 weeks to connect a site. And with minimal impact. While I'm talking, Ahmed, maybe if you can pull up that document that we send to a clinic to prompt them for what kind of time we expect from them, but it's really very little. We have quite a bit of experience in tackling these EHRs, and we do it in a series of validation cycles. We start by doing our first best data pool using the same extractions that we would have in another system of the same vendor that we might have encountered before. We do a very rapid front-end to back-end validation to detect anything that we missed, and then we go back and we cycle again. We do a second validation. These are typically spread out a week to 2 weeks, but mostly because of scheduling issues between ourselves and the end user. The amount of time that we expect of the programmers over here, relatively minimal. I'll ask Ahmed in a minute to project the document of that. But basically 3 separate steps. 1, the establishment of a VPN tunnel that goes from the cloud, whatever cloud you're running to wherever these source systems are housed. That's typically 1 hour to 2 hours of a technical person that can help us set up a VPN. That's one time. If we need, obviously, the access to the EHR tools, and we will work with the EHR table directly at the SQL back end of them. Although there's some places that want to push data out to us, and that's also acceptable. We prefer to pull the data for you. We have a lot of experience because many times within a system, a clinician may put the data that we're after, say a foot exam, could go into an EHR 3 or 4 different ways. And we want to make sure that we map all of those ways in the way that you're using the tool. And then in some cases, we have to drill down to using a textual part of the encounter and using our text extractors to do that. So typically, about 6 weeks is what I advertise after it, provided we have a signed contract at the beginning of those 6 weeks in the sense of access to it. We, of course, need to be a business associate. And the cycles are really 3 cycles of 2 weeks, if you want to think about it that way. At the end of the first 2 weeks, we have your first pass at looking at these tables here. We actually push them all the way down, and we show you a registry and show one of your clinicians a registry who's willing to work with us. It could be a nurse, it could be anybody that has access to your front-end system. And we actually look up a patient in SQI and we compare each and every one of these elements. We locate situations where there might be something that's missing on our end. Perhaps we don't have a foot exam for that patient. We discover that you're indeed putting it in a different location.
Yes.
Go ahead.
So just letting you know that I'm showing actually the implementation process.
Okay, if you wanna take over the screen.
Yeah, I'm showing that on the screen already. So.
Oh, okay. I have been. Okay, great. So there's the process. If you can scroll up to the top a little bit. So it starts with a signed contract and the VPN setup, and then getting access to the clinic's database, and then starting the 3 cycles of validation. Sometimes we don't need 3. We can get it done in 2. It rarely takes over 3 cycles to get the process done. And in terms of the refresh cycles, Dr. Winstein, we can do it however often you want. The impact, our impact is very, very minimal. We do incremental loads where at all possible, and we do those extractions in the middle of the night. We can schedule them in the middle of the night. Any of those is acceptable. Here's the time estimates that we give for the network administrator setup time. This would be the ones in blue would be 1 per EHR. I think I heard you have 3 different systems: an Allscript Professional, Allscript Enterprise, and a Cerner. So it would be 3 of those, setting up 3 VPN to those 3 locations, and then within each of those doing a couple of work with whoever's administering the medical system to get us the application overview, and then these somebody in the staff that can work with us on the validation step.
Thank you. It's going to be helpful to us at the end to if you can get us reference clients that we can talk to that have gone through this process, so we can get a better
Sure.
feel of what might be involved, and probably a reference client for each of the EHRs, the different kinds of EHRs that we have.
All right.
I'm going to hand you over to Dr. Fox.
Anyone else have any questions? Raul?
With Dr. Vasquez.
Tomas says, Dr. V, a question for you, for me is, in terms of state connections, if you have to transfer some of this data, what's your experience with dealing with different states in terms of their requirements and fields and mapping and all that stuff?
Transmission to what, Dr. Vasquez?
State, for example, in a health home model, they want certain metrics transferred over. How?
Yeah.
This device, how does it work? And also, does it do OCR in terms of some of those documents, if we wanted to capture some of that data or no?
Yes, yeah, okay. So the first question, if I understand correctly, the process has to do with the metrics and that we might offer. And the, let me pull up the SQI metric dashboard. So these metrics metrics can be made to match any of the state, thank you, I forgot I wasn't showing my screen. These metrics can be made to match any of the medical home requirements state by state, although many of them are very similar. The issue really is which ones are they wanting you to report? What is the denominator? Do they allow you to use your problem list in lieu of the HEDIS type of discovery or not? And we can do it either way. In fact, most of the time we publish all of the different kinds of metrics. One example is that at Palo Alto, I was internally managing to the metrics from the problem list. So I would map to these metrics here that come out of the problem list. But when I was reporting out, I might have to report out using the metrics from the HEDIS criteria. So you might send a score of 48 for this metric, whereas internally you know that you're doing 47% if you use the diabetes problem list as an indicator. But our approach is to be exhaustive. As many different metrics as are required in your state will get published and added here. It's very easy for us to add a metric because it is just as easy as for us to add these concepts here. These concepts are fully extensible both by us and by the clinic itself and the programmers in a clinic setting. So any concept that has not been pulled out or measured. So for example, we added for a safety net clinic in Kansas City, all of the UBS kind of metrics that they wanted to pull out for the report. And that took less than a couple of weeks of turning that around for them. And then as far as the OCR, our approach to document handling is, and I will be setting up a time, Dr. Vasquez, to talk to you personally, particularly about the issues of ACO and document handling, so I'll give more detail there. But a document in our system uses we call it a shared document. We treat it as a two-part document. On the one side is a PDF kind of view that you basically see the document. You can use it to view it, to fax it, to view something. So it looks literally like a PDF like this. Many PDFs and many documents that we receive from external systems already are in real PDF mode of text and image, which means that these characters here are actually textual. In this one, it is just an image. So there you need to execute what's called an OCR that you mentioned, optical character recognition, to turn first these views into text before you apply textual extraction mechanisms. Additionally, we tag these documents with an XML path to it. XML is a language, if you wish, in which databases can pass data pair elements, meaning the PCP name in this field is Elaine Davis, so an XML tag to that would assert that the PCP equals Elaine Davis. And you begin to extract data from within these systems as and within these documents as relevant, and tag them that way. In the example I gave before of pulling data out of text systems, we did not have to do the OCR because those documents were in Word to begin with. If they're truly just a fax that's received, you have to go through the OCR process, or we can work with the upstream vendor to actually pass us the textual piece to avoid the OCR step. But yes, we can support either one. We have a vendor that provides us the OCR capabilities of turning a document to an OCR, a PDF that's just an image into a PDF that has image and text. and then we can apply our text searching criteria to it.
One more question.
When you set up the population manager, is there a charge after a while for every measure you put in, or is it pretty much, can our programmers do that, or does it, is it?
Yes, your programmers can do that. We can discuss the pricing model with you before, but think of it as really you're renting the software on a monthly basis, and it is all inclusive, and these columns that get added here are no cost, and the development of a fairly complex new one, if you want me to pull on a document that I've never seen, we might work with a one-time charge for you to grab some faxes that are coming from a drug addiction type of center. We work, one of my mentors is Don Holloway, who co-founded the Network for the Improvement of Addiction Treatment called NIATEX. And those types of documents might arrive in a fax version. They might be something that you want us to do. We would contract with you, or you can contract with a program to get those concepts into the system. So we allow user extensibility as well as we can drive that for you. But there's no ongoing charge. We would charge you more per metric. As many metrics as you want to define here is what you're doing.
What about the EHR integration in terms of fees and how you do that? That's going to be important to me also.
Excuse me, the EHR integration?
Yeah, if you're going to tie this into like and the users, I mean, so when you have a program like this, let's say there's 1,000 users, is that also attributed to the cost?
No, there's no per user setting. We charge per installation, which means that if you're the owner of a clinic, you are managing those medical records for that clinic, then the charge is proportional to that. It's just per clinic, essentially. We have not gone into the area of pricing care management. We don't consider those any different than providers, and we're not going to go there. We do look at a new connection charge when you're connecting two clinics that have not been connected before. So in order to establish, for example, these kinds of links, to have a hospital pass ER data or discharge data, we have an installation charge to make sure that we program whatever this hospital is putting out to whatever you want to get. That's a setup charge for that fee, for the feed. Again, I can discuss the cost structures in detail with you, but our philosophy is that one box represents really an entity that is owns the owns the medical record. This clinic is responsible from a HIPAA point of view from all of the medical records that are deposited here, regardless of how many providers are working with it.
Okay. Go ahead, John.
This is John Hennessy from Kaleida Health. Just a question in regards to what you just said means that a provider group will have access to only their patients and their patient information and their dashboards compared to across all of our clinics with the different EMRs sharing that data? Is that what I heard?
Are you saying each clinic will only have access to the data from their EHR?
Think of it in a manner of, we have 4 practices that use the same EHR. So
yeah.
When a provider goes in, are they able to see the information from all 4 of those practices that run on the
yes.
EHR? But
yes,
they're not able to see the other 6 that run a different EHR.
Well, that's all done with permissions. A clinic, for example, that has 4 sites all running under Allscripts Professional, it depends on your ownership of those records. If that is literally one clinic that has the rights to all of those 4 locations or sites, as you call them, then all of the providers could have access to it with no problem. You would basically tell me what the permission levels are here. So for example, I showed you that Elaine Davis is here. If she expands this out to a department, so the department would be a site in your, so if we look at Middlefield, she's now looking at everybody that worked with her in the Middlefield location. If she looks at another site, if she has permission to look at another site, she's looking at all of the patients in the St. Joseph site. And then if you're looking at the entire, this would be your name of your clinic up here, you're looking at all of the patients across all of your sites. That's done by permissions of each user, so I can map you to whatever you want. If you literally have 2 different clinics with 2 different EHRs, so here's one group with Cerner and one group with eClinical Works or with Allscripts. There are 2 ways of doing that. Number one, depending on the permissions, this clinician can actually log on to this system if they have permission to do that. Or if what you're referring to is that there should be some data that passes from one group to another and gets integrated with this provider's panel. That's probably the operation that you're talking about, but I'm not sure. So that one provider at one clinic, for example, Dr. Davis, would be looking at her panel, but maybe some columns here come from a transmission from a different clinic, so that the last weight and height maybe was measured at a different clinic. Those would require data feeds from one to the other, obviously. And that's precisely what we want to do. You can do those in this manner. You could do a regional registry, for example, where all of your asthmatics are sharing one registry, and then all of your providers access the registry that is in the collection unit. That's another way of doing it. There are many different ways of instantiating that. It really depends on your preference and your handling of permissions, whether you want one group is allowed to see data from the other group or not, or whether you want to do that on a limited basis by creating regional disease registries, like all your diabetics from all of these entities could be viewed in a single integrated panel here. So when you look at the diabetics here, you'd be looking at data that was integrated already from all of the separate clinics.
So to go on what you had just said, when I think of some of the detailed information that you're looking at, let's say a patient goes from a clinic to a specialist for their eye exam, and they do some detailed information. You're receiving that information from the PCP's EMR, not the specialist, when you're looking at what is completed at what times.
Right.
Okay.
Yeah, so if the ophthalmology sends a report back to you saying that they've done the diabetic eye exam, I can, if that report actually arrives back in your clinic, then it'll come in through the ETL. We'll receive that report, we'll map that into the right concept, and it'll appear the next refresh in your system. So that's one method where it's coming physically, it's coming in as a document. For example, you send a referral out to a ophthalmology, you get the PDF or the report back from ophthalmology coming back. The second method is that the ophthalmologist has one of these units, and I doubt that that's going to be the case, but we could send data from one clinic to another, or have them both sharing on a registry. So probably you're talking about the first method in your case, but
personally.
I can do it either
want
way.
EMR anyways.
What?
I'm just-
The, Tomas, I have two questions, sort of use cases that I'd like you to go over, maybe three. The first one is on the patient summary. Is there a way
Right.
of creating, I understand you can go to the registry and create an individual summary, but from a workflow point of view, what's easier for me is how would I do it? I have a schedule tomorrow where I'm seeing 14 of my patients, and I want patient summaries on those 14 to look at. How would I do that?
Right. So the easiest way, there's a column called Next Primary Care Visit. I would one thing that I don't have this column populated very realistically, but you could filter on the Next Primary Care Visit, which yeah. So you would put Next Primary Care Visit is tomorrow, is equal to, when you put whatever date, and pull the list of patients that have a visit tomorrow, and then these patient summaries need to be printed. We can also write you a macro to do that
Yeah,
automatically, and you can write that as well.
Yeah, that was my question. That could be done automatically, macro printed. Could it also be put
Yeah.
onto
So when you want to do it, to queue up all of these patient summaries to the printer on each day, that could be done in a night job, for example.
Is there a way,
If
other
that's
than
your
printing it,
flow.
that it could be put on a screen that I could see on my laptop, or that my nurse could see on her laptop, rather than having to do the paper route?
Yeah, I mean, these are literally PDFs that are, these can be saved as PDFs, dropped down into your laptop. They can be viewed in a separate window that you have open, so that you toggling between your EHR and this. At Palo Alto, we were pushing these alerts back to the EHR. In many cases, the Epic system, which I was working with, had some of these things called alerts. In 2007, we did a very interesting study of the effectiveness of alerts when they popped up in front of the provider using the EHR versus when they were provided in a list like this, versus the follow-up done in between visits with the follow-up tools that we have, and turned out that some of the alerts that pop up are not as useful, in the sense that the
we're well aware of alert fatigue.
Yeah, we call it the popcorn effect, because a lot of things kept popping up and people were just killing it. They just didn't care for it, and we were having effectiveness things of about 15 to 20%, meaning that 15 to 20% of the doctors responded to the alert and actually completed the item within, I think we were measuring even 7 days for them to follow up on.
And again, even though it's my patients, could I designate a staff member to see my schedule, print these out?
Absolutely,
like my medical
and in
office
fact,
assistant?
that's sort of the flow that we were doing. So a nurse will have her own login, and your nurse can pull up all the patients from your list, and he or she can be working with your patient list. And that was actually our flow.
Dr. Vasquez has a question on this. Then I'll go to the next use case that I need.
So my question is, so now we're tied into the electronic record. How do we get access from out of it, sort of through a virtual PC or a mobile device, so that we can have some other team players help this particular office with a diabetic group that's a problem, so that a case manager can use it, but not integrated into the system, coming from the outside? How does it tie in?
Yeah, anybody that you give permission to, Dr. Vasquez, can log in to the user and get their views. So in the case of Alice here, Alice, who was a care manager that I was pretending was the diabetes care coordinator, is logging on her device. It can be an iPad, it can be anything that supports a browser, and they can be looking at at her list, which you have been populating for her at your end by pushing patients in her direction using the care manager application. So Alice doesn't have to be part of your system, and she can, again, when she's done with those patients, she can select them and pass them back to a worker in your area to graduate them or to assign them to somebody else. So this is precisely this part of the tool was developed to help manage the care coordination outside of your facility.
Yeah, Tomas, so how do I manage Alice? I mean, how do I know that when I put the information, Alice is being done in a sort of a tracking system? How do I coordinate the care that way so that if she doesn't respond within a certain time, does it go, do you have the capability to trigger somebody else? Maybe her supervisor?
Yeah, for example, if what you're saying is that you're trying to monitor that Alice then makes an appointment with that patient, is that what you're talking about, or that she enters some data on that patient? You are still seeing those patients, and your nurse is seeing those patients in your own list as well.
I think what he's asking, is there a way to put an automatic tracking in to say this is overdue? You know, that Alice was supposed to schedule a care management visit for, say, a health risk assessment, and it's now, and there's a timeline, so it's 3 months. So after 3 months, if it's not done, there's an overdue list of Alice's patients that don't have health risk assessments.
Yeah, absolutely. We would have a column here called health risk assessment, for example, with a date, and it's a metric like anything else. Look for a health risk assessment that is not done after X amount of time of assigning it to her panel. So you can trigger that back to your arena. So think of these columns here as representing anything that you want that can be obtained from Alice's system or from your system. So if she handles the patient and puts some data into the patient, it will reflect back into your system as well. So exception lists can be made. You could have a metric that would say health risk assessment done within 3 months, and you would see 20% here, and you could dial Alice as the provider. So you can actually be drilling down to the patients that Alice has and whether she's following up on them or not.
The second use case, which is really important for PCMH, which they've gotten into, is the idea of results tracking. Lab results we seem to be okay because we have bidirectional interfaces, but referrals, overdue referrals, overdue x-rays. So let me give you another use case. I order, say, an ankle x-ray on Joe Smith, and Joe Smith doesn't go, and there's no, well, Joe Smith goes and gets the ankle x-ray over at BGH, and I have the result and it's scanned back in, but now I'm getting an overdue task in my all scripts because it says 3 months, Joe Smith doesn't have an ankle x-ray. So now we have to have a medical staff person go in, review the chart, go back to the order, say, oh, an ankle x-ray was done, let's close the order. So how do I create, if I put the order in, that when the ankle x-ray comes back in to the EMR, that it automatically closes that order as resulted?
Right. So again, so the result of the
can you do that? Can you create that loop?
Absolutely. So, for example, the receipt of a document, and pretend this is an X-ray report, again, I have to be able to get into it and either OCR it or see by some mechanism that this was actually an ankle X-ray. He might have gone in to get a lung X-ray, which is not going to satisfy your order. So I can do that either by CPT codes, I can do it by looking at the text, actually, but yes, one of the most important functions that we were doing was automating the completion of external orders that were coming back as documents. I designed a whole intake process for all of in 2006, we officially converted our medical record from paper-based to electronic-based. Even though we had Epic already up for about 5 years, we were legally still maintaining the paper record. And when we had to cut over that, we had to take every single piece of paper that can come in as a response, anything that in report of the x-rays that coming externally to our clinic, and make it part of the record. So I designed the process to do the intake of all of the PDF documents and tie them, as you're talking about, into your all script. I'm not sure why they didn't tie it in already to satisfy that, that order, which you can do, but I certainly can tie it back to the order in my system and have the tracking occur here. So you would have a column here that would say external x-ray done, and any order that you place out would manifest itself as a pending order, and we could have a count here of the pending orders that are missing, and then.
So we could do that. So we could do a metrics table against that, so that we could follow, say, monthly or others, how many overdue
Absolutely,
X-rays
and
there
I would
are, how
typically,
overdue referrals. This is just a critical feature of PCMH, which I think if we can show it would help greatly. Just having that up would help, right, Meredith? Did you have any questions, or? No?
I would just comment from a Kaleida UBMD perspective.
is there a question from Meredith? Or?
No, this is more internal.
We're going to have an internal discussion.
Yeah.
Okay.
I would expect radiology orders and results can match up also. I mean, so we may want to, if that's an issue, we should really talk about it, because today you are getting the results.
I can't hear if they're asking a question.
We're having, there's a sidebar discussion, Tomas.
Oh, okay, all right.
You're not bringing in.
There's a sidebar discussion between you and Kaleida about how to link X-rays and reports into the all scripts.
We
So they think
push out radiology reports, so you just start taking them. I didn't understand.
Yeah, there are ways to link that directly into HR.
Sorry.
No, that's okay. We did want to have an internal
You got it.
discussion.
All right.
That's all we had. Charlotte has a question.
Hi. My question is there any way to backdate the data? So, for example, you could create a list of patients who, a list of patients who in June had not had an HbA1c, but then you could create it so every month you could see sort of how things have changed. Is there any way to do that in the system?
Yeah, well, you're doing that on an ongoing basis. I think I showed this. Every single month, we do a reading of the numerator and the denominator for any kind of metric that you have going for every provider and for the entire clinic as a whole. So, so you are at any given point, once you have these goings, I think that I showed it earlier, you have trends of 2 years worth of data to show you the score that Elaine Davis had now versus what she had earlier in the year. These are captured every month. We can capture them even more frequently than that, but that seems adequate. It is very hard to today go back to January and back populate that kind of data, because the patient might not have been even a diabetic or might have not been diagnosed as a diabetic then. So it is quite difficult to generate some of these clinical data backwards for you to get you started, but as soon as you go live, we're capturing on a regular basis the score, so you do see the change. And in fact, that's really what you want to track. I don't know if I showed it over here, but the kinds of improvement that you would want to do, you would track over time. Here's the first 4 readings of our graphs. Here's multiple readings of patient satisfaction across time. So the idea is over time you're capturing the trend in these kinds of graphs. The only problem with back populating, if you literally mean for me to come in today and tell you things about last May, the problem is that the denominator, the number of patients that I have to check that they've had an A1C, may have changed then. Your problem list may show that they're on the diabetes now, but to construct a list of patients that were with your practice at that time back in May gets quite complicated, and actually we haven't found it to be useful. We found it useful to just start tracking your things and going forward and show improvements there.
Tomas, the other question is, if you're bringing in other EHRs, I mean, so you have Allscript, what's your experience with behavioral software in terms of, like, what is it, 1011 or Osasis, all these other types, interfacing them to something like this?
Yeah, most of the work that we were doing with behavioral care in Palo Alto, which we had a fairly nicely designed integrated program, our psychiatry department was co-located next to family practice because of our philosophy of really co-managing patients and so forth. And most of their data is in dictated or textual form. So we would pull a lot of those elements from the text report. We also get, obviously, the ICD-9s, the CPTs, and the medications that are coming from those systems. Those are pretty much available in the same format that your meds are. But some of the practices are completely paper-based, and again, we use our paper scanning technology to integrate practices that are still on paper or on paper-like forms. I can send you, we also offer a tablet-like product in which you can take your PDF form and start having them enter the same data that they were entering before in the same format, but now generate a trackable PDF. So we've used that technique as well. I can send you a little video I made of the use of those tablets, Dr. Vasquez. So that
I think that Dr. Vasquez I saw that video, and I think Dr. Vasquez should see that video, especially on
I'll send
it.
that.
Actually, probably, if you wouldn't mind everyone seeing it, I think it'd be also important for the hospital to see it. The idea of this tablet is you can literally it literally can replace paper. You know, so that so instead of checking it off on paper and entering the data, we'll enter the data, create a PDF for you.
Yeah, these are tablets like the Rico tablet. There's a Toshiba tablet of the same kind, which are pen.
Yeah, if you send the video to John,
okay,
we'll send it around. It's only a 5-minute video.
Right.
It's a crude. It's not a polished video. This is
Yeah,
not a market. It's definitely not a marketing piece. So look for content, not style, on video. So I'll apologize. I think you answered my question. Some of the clinics that we may be working with, especially if ECMC comes on board, if they like this, aren't live yet with their EMR. So could they, would you, I understand it'd obviously be additional charge if you were scanning in, loading the data, but it'd also be a charge if they had to load the data in themselves, you know, from their paper-based chart. So you could, what I'm hearing is, and I'm just summarizing, that you could take that, scan those in, and help populate the new EMR from day one, you know, off their paper record. Is that correct?
That's correct. The integration of documents is a very important step that we're working very aggressively in, Dr. Fox, and I've shown you some of the design and the full integration of what's called a shared record, really a concept of a record that has on the one side a visual piece of paper that could be the things that we had in our medical records a long time ago, and an XML site that contains the content in a way that the computer understands. And you can see the beginnings of that in the HIE talk of the CCDs and the CCRs, continuity care documents and records. And the idea that eventually, just about, you know, in my opinion, had we been invented the EHR today, we'd be doing that for just about everything, every patient.
By the same token, let's say for example, Allscripts is having financial trouble now, and let's say they go belly up and we have to switch to another EMR. Could we use this
Correct.
data out of this data set to populate a new EMR rather than have to do that?
That's correct, and we use that, for example, at Palo Alto. We switched over from our practice management system, which was IDX. About 2006, we switched over to Epic, and we use the system to backpopulate and to use it for a lot of other ancillary things. We did a lot of studies of ICD-9, ICD-10, projecting our conversion costs and stuff that way.
We've gone a little bit over, but I think it's been very worthwhile. If anyone, thank you, Tomas, George, Ahmad, all the people that were there. Very informative presentation. If there are any burning last questions, I'll open the microphone for burning last questions. We have a burning last question.
You had mentioned that the population management was programmable on our end. I was wondering what is there a GUI for that, or is it code? And if so, what's the language? And are these reports exportable to Excel?
Yeah, everything is exportable to Excel and to PDF. This is all written on a Postgres server, and really you have access to the SQL directly through it. The columns here are definable mostly on table format. So you basically define one of these concepts by adding a row to a column. And we teach and we train people in places as large as you would have 2 or 3 what we call level 3 analysts that would get down to that level of adding a column to a table.
Okay,
And,
thanks.
And the access to the database is native SQL. You can do anything you want with it.
One more question.
No questions. I just want to thank you. I think we'll close now because we want to have some time for internal discussion on this. Thank you so much, Tomas. We appreciate it.
All right, you guys take care.
Take care. Bye.
Bye-bye.